صباح الخير. Good morning, everybody. It is my pleasure this morning to start our session about psoriasis basics, and it is my honor and pleasure to welcome two very eminent international speakers that have accepted our invitation to come to Egypt, Professor Peter van der Kerkhoff and Professor George Prince. And in time, I'm going to introduce them. They're going to give us a lot of experience and insight about psoriasis. But now we are going to start with my dear colleague. Yes, she is much younger than I am, Professor Marwa Amir. She's an assistant professor in Cairo University, an excellent speaker, and she's going to talk about pathogenesis of psoriasis. So Marwa, please start.
Good morning, everyone. I'm very happy to be here today. I'm starting with the pathogenesis of psoriasis, and I'll try to make it as simplified and as clinically applied as possible. Speaking of psoriasis, we always say it's a chronic, it's autoimmune, it's multifactorial disease, it has a polygenic inheritance, it has environmental triggers that leads to immune dysregulation where both innate and adaptive immunity are involved. Speaking of the polygenic inheritance of psoriasis, yes, it has a positive family history with variable incidence in different countries. We have multiple psoriasis susceptibility loci with source from 1 to 10, with 1 the most implicated. The incidence is higher in twins, especially in monozygotic twins. The risk and exacerbating factors are multiple, and I believe they will be discussed in details in the next talk, so I will skip this part of triggers and the mechanisms behind these triggers, the epigenetics and other mechanisms. So I will start with the immune dysregulation. When we speak of psoriasis, we have variable cells of the innate immunity, many cells of the adaptive immunity, and a very complex network of cytokines trying to connect both arms of immunity. So how it starts? This is a very simplified form of pathogenesis that starts with the sensitization phase, the phase of autoantigens, antigen processing, and presentation. At this stage, we still don't have visible skin lesions, and this is followed by the silent phase with variable duration and ends with the effector phase. In the effector phase, we have a genesis of many effector cells, whether T cells and other immune cells, that migrate to the skin and lead to the keratinocyte response. It is very important to note that our patients usually circulate between the silent phase and effector phase once the sensitization phase occurs, meaning that our patients will never go back beyond the sensitization phase. And this is one of the reasons why psoriasis is a chronic disease. Starting with the sensitization phase, the phase of antigen presentation, what are the autoantigens in psoriasis? The most recognized are the antimicrobial peptides known as the chemical shield or the alarmines. They are usually produced in response to threats. They are markedly elevated in psoriasis. We have also the peptide fragment of keratin 17 and the lipid antigen of phospholipase A2G. However, we have another important autoantigen, which is the melanocytic autoantigen, ADAM-TSL5, and it is highlighted in a different color because it works in a different mechanisms that will be mentioned now. So, how these autoantigens start the process? When a genetically susceptible patient is exposed to a trigger, this will lead to overproduction of antimicrobial peptides, especially the LL37, that can act directly either on keratinocytes or indirectly through forming complexes with toll-like receptors, toll-like receptor 7 and 9 on plasmacytoid dendritic cell, toll-like receptor 8 on myeloid dendritic cell, and at this stage is also activation of the other cells of the innate immune system, like the macrophages and the natural killer cell, and under the impact of tumor necrosis factor alpha, interferon gamma, interleukin 1 and 6, the immature myeloid dendritic cell will be activated to the mature dendritic cell that will leave the skin to the lymph nodes. So this is the first step. And it is important to note that the major players at this phase are the tumor necrosis factor alpha and the interferon gamma, and this was the rationale for developing the anti-TNF biologics, the first biologics to develop. Then in the lymph nodes, another important step occurs, which is the immunological synapse, or where three main steps occur. There is a form of communication between the dendritic cell, the mature one, and the naive CD4 T cell. The first one is interaction between the T cell receptor and the major histocompatibility class 2. And the second one is called the co-stimulation that involves the interaction of 3 pairs of molecules between both cells. And this is followed by the release of soluble mediators. So in the lymph node, the next step is the T cell polarization after the interaction of the naive CD4 with the mature dendritic cell. Under the impact of interleukin 12, the CD4 naive cell can change to the Th1 cell. The Th1 cell can produce again TNF and interferons, and it is very important in cell-mediated immunity. Or polarization can occur into Th17 cells under the impact of interleukin 23 and ROR gamma pathway, and it produces interleukin 17A and F mainly with interleukin 22. This step is very important in immunity against fungi and is very also important in regulation of the autoimmunity and autoimmune diseases. Under the impact of transforming growth factor beta and FOXP3, the naive CD4 cells can change into T regulatory cells, and these are the helpful cells that are responsible for the immune tolerance. This is why these cells are dysfunctional or deficient in many autoimmune diseases, including psoriasis. And also we have other sets of cells. I think we can understand why the biologics working against TNF mainly can be implicated more in reactivation of TB, for example, because the Th1 mainly is implicated in cell-mediated immunity, and why the IL-17 blockers we can see some fungal infections because they are mainly important in immunity against fungal infections. So the Th17 is a major player. Th1 is no longer under the spotlight, and other cells also of the innate immune system are under the spotlight, like innate lymphoid cells and gamma delta T cells. So now we generated effector T cells. What will happen next is the migration from the lymph node back to the skin through the bloodstream. So how do they leave the bloodstream to the skin? It's a very complex process that can be simplified by this diagram. The first step is the rolling, where the cells spin around themselves and around each other. This will slow the bloodstream, giving a chance for the cells to adhere to the inner aspect of the blood vessel. They trigger their adhesion molecules, they adhere to the inner aspect, and then by a process called diapedesis, where the cells start to squeeze themselves in the pores between the endothelial cells to leave the bloodstream and migrate to the skin. This is a very complex process with many adhesion molecules, but it can be simplified in this diagram. So now we are in the skin. What will happen next? That the mediators of the Th1, Th17, and other immune cells will work on the keratinocytes. And the keratinocytes, in turn, will produce the keratinocyte response. At first, it was thought that keratinocytes are innocent bystander, meaning their main role is just to hyperproliferate. The cell cycle is shorter, the cell population is doubled, and so on. However, it was found later on that keratinocytes are active cells responsible for production of several mediators that will be discussed later on. This is why we see clinically hyperkeratosis, parakeratosis, because the cells hyperproliferate and there's defective differentiation. And then the keratinocytes themselves will produce the interleukin 17 and the tumor necrosis factor alpha and the interleukin 22 and several chemokines. So this what creates what's called the inflammatory loop. The process started with the triggers on keratinocytes and ended with formation of T cells that will act again on keratinocytes, and this will create a vicious circle of inflammation known as the inflammatory loop. So it is very important that blocking the interleukin 23 or interleukin 17 will help to break this inflammatory loop and stop the vicious circle of inflammation. And further understanding of the pathogenesis and the molecular pathogenesis led to further understanding of the structure of the cytokines themselves, starting first with the shared P40 subunit of interleukin 12 and interleukin 23 that led to development of ustekinumab, and then further understanding of the P19 for more selectivity and safety that led to development of gozelikomab and risankizumab, and the interleukin 17 with the secukinumab and exkizumab. This is how pathogenesis helps us to understand the clinical presentation and the background of therapeutics. And again, through the JAK-STAT pathway, led to further understanding of the process. We have the JAK inhibitors used more in rheumatological setting, but we have also a TEC2 inhibitor that is FDA approved, the deucravacitinib, that works on the TEC2, blocking the phosphorylation of the JAK-STAT pathway and preventing the response of Th1 and Th17. So if you remember, there was an autoantigen that we mentioned that works in another way than what we mentioned before. That is a melanocytic antigen. How it is different? First, it is not related to keratinocytes, it is related to the melanocytes. And second, it interacts with the CD8 cells, not the CD4 cells. And this interaction will lead to production of interleukin-17 that will act on the keratinocytes. And this is another way how psoriasis develops. And this leads to an important question. Do we have other cells that produce interleukin-17 apart from Th17 and apart from keratinocytes? Yes, we have the CD8 T cells, the gamma delta T cells, the mast cells, the neutrophils, the natural killer cells. What about neutrophils? Neutrophils are major players in the pathogenesis of psoriasis as well because they are a factory of production of several chemokines and cytokines, and also they have target receptors for several chemokines and cytokines. And neutrophils can act by several ways. First, they can act on keratinocytes through producing interleukin-17. And then they can recruit other neutrophils where they can form Gauge and Monroe microabscesses in the epidermis. And the third, a process called netosis, which is a very important step in autoinflammation and in autoimmunity that leads to overproduction of interleukin-17. We have a very important role for angiogenesis in psoriasis, and it's a very common rule that any disease hyperproliferative, whether inflammatory or neoplastic, will require angiogenesis. And we have increased level of vascular endothelial growth factor and other mediators that lead to formation of the dilated tortuous capillaries we see in histopathological examination that will give the lesions its erythematous color and the Auspitz sign. It's very important to know that are shared common pathways between psoriasis and its comorbidities. For example, for psoriatic arthritis, we still have more or less similar mechanism, starting with the naive CD4 T cells, the dendritic cells, the interleukin-17, the interleukin-23. And this will explain many of the comorbidities associated with psoriasis. So, to sum up this diagram, it's how it all started with the innate immunity in the first exposure, the LL37 that will lead through several mechanisms into the activation of dendritic cells to be mature, to go to the lymph nodes where T cell polarization occurs, ends with formation of Th1 and Th17, with production of the main mediators. Definitely there are other mediators, but these are the main, that will act on keratinocytes, leading to the keratinocytes response, where they hyperproliferate, but also important active cells that produce all these cytokines and chemokines, and the inflammatory loop will keep on going in a vicious circle. And these are the major players. Definitely, I don't have time to discuss all the aspects of pathogenesis, but this is very important for further reading for those who are interested. The barrier defect in psoriasis is very important. The role of mast cells, how pruritus develops in psoriasis. Definitely, you have been in the era of tissue-resident memory T cells in psoriasis for the past 10 years or so, and this is very important and important targets for many therapies, the gut dysbiosis and the interleukin-36. Thank you.
Thank you, Marwa, for an amazing presentation. Professor Prince or Professor Peter, do you have any comments on Marwa's talk? Because it's really amazing. And you managed to do it in 12 minutes, which is, yes, very hard. Any comments?
I think this really is a great talk. It demonstrates very well also the mode of action of the innovative targeted treatments that we have, and the results from the treatment reflect that what has been found in the pathogenesis of psoriasis is actually relevant. It's relevant to disease. They are not epiphenomena, but they are very relevant. I would like to ask you a question. There's the IL-17 production without IL-23. Do you think that IL-17 and IL-23 is coupled to the extent that always for IL-17 production there is IL-23 behind it, or is it also possible that there is some IL-17 production which is not under the control of IL-23? That aspect, of course, is important considering the side effects of anti-IL-7s, anti-IL-23s, and yeah, perhaps you have ideas.
We have pathogenic Th17 and non-pathogenic Th17. So under the effect of transforming growth factor beta, we can develop non-pathogenic Th17, and this is very important to maintaining the balance and prevent autoimmune diseases. And this might explain also the production of, also have production of interleukin 17 from other cells like the natural killer cell, the gamma delta T cell, the CD8 cells, the mast cells, the neutrophils, and others. And this is why mainly the IL-17 blockers could be implicated in sometimes in exacerbation of some inflammatory bowel diseases. However, we don't do this with interleukin 23 blockers. So did I answer your question properly or miss something? Yes, thank you.
Yeah.
Thank you, Marwa. Now I have the pleasure of introducing Professor Jörg Christoph Prinz, who is from the Department of Dermatology and Allergy, University Hospital, Ludwig Maximilian University in Munich in Germany. Professor Prinz is all his work clinically and research-based is on psoriasis. He established a psoriasis outpatient clinic. He's focusing on his experimental research on the analysis of the T-cell mediated immunopathogenesis of psoriasis and the identification of target cells and autoantigens of the pathogenic psoriasis autoimmune response. Professor Prinz, thank you for accepting our invitation and welcome to Cairo. Thank you.
Yes, dear colleagues, first of all, I want to thank you for the opportunity to speak here, for the invitation to come to Cairo and to enjoy this generous hospitality that you give to Peter and me, as we recognize, making us feel like kings, even though my name is Prince. And it's really a great pleasure to be here. After this talk of Dr. Marwa Amar, I want to extend the understanding of the pathogenesis of psoriasis a little bit from my own research, since I have been dealing experimentally with psoriasis for about 30 years, always trying to understand the role of T cells in psoriasis. And this also means that I will integrate some of the most recent data into my talk that may forward the understanding that we just heard in the previous talk. Looking for the triggers of psoriasis means that we first have to take a look in the pathogenesis of psoriasis. We know that it is a quite complex disease with many different phenotypes that you see here for the skin and for the arthritis. However, patients only get psoriasis if they have one of the 20,000 different HLA alleles, which are HLA CO602, or HLA-B27, as was mentioned before, or some less frequently associated HLA alleles from the HLA-CO7 group. And that means, actually, these are the disease-defining HLA alleles, and when we want to understand the pathogenesis of psoriasis within the complex genetic predisposition, we have to define what these HLA alleles do finally. And to understand this, we have to look at the actual role of HLA class 1 molecules. HLA class 1 molecules present peptides which are derived from the cytoplasmic proteins, from the proteins within a cell to the CD8 T cells. And these peptides are generated by proteolytic cleavage of the cytoplasmic proteins. They are loaded onto the HLA class 1 molecules in the endoplasmic reticulum, and then they are finally presented to the CD8 T cells on the cell surface. And there are about several thousand self-peptides on the cell surface being presented, which correspond to about 50% of the proteome of a cell. So this is the main interaction with the T cell receptor, which determines the HLA restriction and the antigen specificity of a T cell at the same time. And this means that actually the most likely role of HLA-CO6 or B27 in psoriasis would be that it mediates an autoimmune response of CD8 T cells against a specific target cell type. It is not so much the autoantigen, the antigen, it is the target cell type by presenting certain specific self-peptides. And in order to identify this, we need the T cell receptor. The role of CD8 T cells has been quite nicely demonstrated by previous studies using human skin transplants from psoriasis patients on mice that are immunodeficient. And these experiments show that if you block the emigration of CD8 of T cells into the epidermis, psoriasis will not develop. And if you then block the activation of CD8 T cells, you can see here by anti-CD8 antibodies, then you get the same blocking of psoriasis development as if you would use TNF-alpha. That means that really CD8 T cells are the ones that are promoting the actual changes that we see in psoriasis. And T cell receptor analysis then also demonstrated that there is a clonal expansion of CD8 T cells by T cells carrying all the same T cell receptor, meaning that there must be some kind of antigen of target cell within the epidermis. And these CD8 T cells produce the psoriatic cytokine IL-17 and generate the psoriatic lesions. How much this holds true, we know from recent single-cell transcriptomic analysis. In these analyses, single cells are dissected from psoriatic sections by laser, and then the transcriptomics can analyze the full expression profile of genes within these cells. And I just want to highlight that it is CD8 T cells in these analyses as well. These are the ones that produce the IL-17, and it's not CD4 T cells. They hardly do anything. They are quiet, they come into the infiltrate, but it's finally the CD8 cells. And you can see here CD8 coincidizes with IL-17 production. What also becomes apparent from these analyses is that the CD8 T cells that are represented here in these sections by the red dots are all lined along the basal membrane, meaning the basal keratinocyte layers. And that means that there must be a target cell within this epidermis which activates the clonal CD8 T cell response that finally produces psoriasis. And that was the issue that I have been dealing with for a long time. And in order to identify these target cells, we need the CD8 T cells. You cannot keep them in culture for a long time, so you have to use some kind of additional or other mechanism. And what we did is we isolated the CD8 T cells from the epidermis. We generated, at this time, well, it was completely new, a method to really characterize, molecularly characterize the alpha and beta chains of single T cells. We cloned these alpha beta chains and transfected them, expressed them into a mouse T reporter hybridoma cell line. This cell line then carries the antigen specificity of the psoriatic immune response up here, and it also carries green fluorescence protein as a reporter gene. And once these T cell receptors here see the antigen context with HLA-CO602, then the reporter cells become green. And this way, you can analyze what are the target cells, and we found it is melanocytes. Once melanocytes expressed HLA-CO602, we could activate the T cell receptors, the hybridomas, but once they are HLA-CO602 negative, nothing happens. And when you look at the histopathology of psoriasis lesions by immunohistology, you can really nicely see that the green CD8 T cells here are found in direct contact with the melanocytes, and you can also show by the polarization of cytokines that these CD8 T cells are activated directly at the contact site with the melanocytes or the dendrites of the melanocytes. And then when you compare, again, the most recent data, then you find that the localization of the CD8 T cells along the basal membrane is exactly what you see in single-cell transcriptomics. So we can clearly say melanocytes are the targets of the autoimmune response. They get activated to produce the keratinocyte alterations, while the CD4 T cells, and that's something that has to be changed because it's a dogma now, it has to be eliminated from understanding. We also looked for the autoantigen that is being presented on the melanocytes. It is a difficult process because T cell receptors behave completely different from antibodies. An antibody is very precisely directed against one particular epitope. A T cell receptor instead is polyspecific. It can recognize up to 1 million different peptide antigens, which are characterized by a certain amino acid pattern, which is determined by those amino acid residues that fix the peptide into the HLA binding groove, and by only one or two amino acids that stick out of this binding groove and then ligate the T cell receptor to activate the T cell. So it is first of all important to define which is the peptide antigen recognition motif, which we do by peptide library screening. You look at about 10, 15, 20 peptides that are being antigenic for a particular T cell receptor, and then you can identify which amino acids are required at certain positions to ligate the T cell receptor. And with this motif, you can search for the autoantigens or antigens, and with this way we identify as a melanocyte antigen. As Dr. Almer mentioned before, we identify the peptide from Adams 5 as the melanocyte antigen. Now this gives the first step in understanding pathogenesis. It is CD8 cells that enter into the epidermis, they get activated, they expand, and they produce the psoriatic phenotype. Now what we know is, and then I come to the actual topic of my talk, which are the triggers of psoriasis. We see that there is a complex genetic predisposition. You only get psoriasis if you have a certain HLA class 1 allele, but not every patient with this composition develops psoriasis. The concordance rate between identical twins regarding psoriasis is somewhere between 20 and 73%. That means you need additional factors, and the disease develops not from birth. It's not a congenital disease, but it develops during lifetime. Here you see the maximum incidence of psoriasis manifestation in male and in female patients. It's about in the age of 15 to 25 years. And that means that there should be certain environmental triggers that activate the autoimmune response. And we know them already by associations. These are streptococcal angina and further conditions like smoking, alcoholic beverages, wheat consumption, or certain microbiota that have a high prevalence in the microbiome. If environmental triggers, infection lifestyle may play a role in triggering psoriasis, it is important that we really identify these antigenic triggers that convert the genetic predisposition into active autoimmune disease, because by this we might develop preventive or therapeutic strategies in psoriasis management. And so my question was, which are environmental triggers that induce psoriasis onset or maintain disease activity? Again, we used this T cell receptor hybridoma that helped us to identify melanocytes. And the first issue was, one of the issues was, how can streptococcal angina, which is the only really confirmed trigger of psoriasis, activate the psoriatic autoimmune response? So we cultured our T cell receptor hybridoma with tonsil cells that we had isolated from the tonsils of patients that had been tonsillectomized due to streptococcal angina in association with their psoriasis. And what you see here in red is the tonsil cells, and in green is the hybridoma that is being activated by co-culture of the hybridoma with the tonsil cells. And by separation of the tonsil cells, we could find out that it is actually the tonsillar B cells that activate this T cell receptor hybridoma, while other tonsillar cells or tonsillar T cells had no activity. And this somehow supported something we found in much earlier studies, where we identified the same T cell clones in the tonsils and in the skin, that somehow the T cells that are being activated in the tonsils migrate to the skin, where they may activate the psoriatic autoimmune response. And this extends our pathogenetic understanding regarding streptococcal angina in a way that during the inflammation of streptococcal tonsillopharyngitis, T cells are being activated, potentially autoreactive T cells are being activated against B cells. Then they somehow find their way into the skin by expansion and induce the psoriatic autoimmune response. And using our peptide recognition motif, we have identified at least 7 different self-peptides in the immunoproteome presented by HLA-CO6 on B cells that can activate this T cell receptor. So it seems we have a cross-reactive autoimmune response between B cells in the tonsils first, and from there the B cells migrate into the skin. Now the second question was, psoriasis is maintained over life and streptococcal pharyngitis is gone after a certain period of time, so it should not be the trigger anymore. What are the environmental triggers in addition? And again, we used our system. We have this T-cell receptor hybridoma that turns green when it sees the antigen, and we searched databases for proteins that may contain this particular peptide recognition motif. And this helped us to identify peptides which activate the T-cell receptor, and they are from microbiota, from Saccharomyces cerevisiae, from tobacco and wheat, that are quite intensely recognized by this T-cell receptor, but that also produce a stimulation of CD8 T cells from psoriasis patients. So we have a number of environmental peptides from environmental sources that correlate somehow with what we know as psoriasis risk conditions. And this is what I want to explain in a little more detail. Saccharomyces cerevisiae is a yeast, and it is necessary to ferment glucose into alcohol in wine and beer. And we know that alcoholic beverages are very strong triggers of psoriasis. I have patients who toast to themselves at New Year with a glass of champagne, and they get a flare of their psoriasis. And the antigens, the peptides of Saccharomyces cerevisiae are always released in alcoholic beverages once they decay, and they may, of course, produce an autoimmune response, since they also induce a TC17 cytokine pattern. And knowing that psoriasis can be promoted or can be induced or triggered by alcoholic beverage, we find that this may be an explanation how alcoholic beverages may induce or trigger psoriasis, in particular since they are also a strong trigger for Crohn's disease, which is being associated with psoriasis. How about tobacco? Smoking is an independent risk factor for psoriasis, and we know that these proteins are being released in the aerosols. Once the tobacco smoke is being inhaled, patients are being exposed. And we also know that it is even sufficient for children with a particular genetic predisposition to be exposed to smoke, tobacco smoke. They can have an increased risk of developing psoriasis. How about the microbiota? The firmicutes are composed of bacteria like Streptococcus agalactiae, Clostridium species, and Flavonifractor plautii, which all have some antigens stimulating our T-cell receptor. And studies from the microbiome show that overrepresentation of these bacteria in the gut microbiota of psoriasis patients are strongly associated with psoriasis development. So also here we have an environmental trigger that may induce or promote psoriatic inflammation. Same with Actinomyces auris, which is a germ from the oral microbiota, which is linked to periodontitis, and periodontitis is highly associated with psoriasis. For me, most important, besides Saccharomyces cerevisiae, is wheat. Wheat exposure. We have two peptides from wheat that activate our T-cell receptor and are highly immunogenic for psoriasis patients. It is known that gluten-free diet may improve psoriasis, but unfortunately controlled studies of gluten exposure are missing because it is quite difficult to make such a study. But dietary wheat alimentation is associated with psoriasis, and some people speculate that even the change of the diet, for example, in Asian countries from rice to wheat, bread, whatever, may explain why psoriasis is increasing in prevalence. We know that gluten-free diet may improve psoriasis, and we have tested this in some patients who had refractory psoriasis that we put on a gluten-free diet. They have to be strict, really adhere to it, and we found that 7 out of 13 patients that could not be controlled by conventional therapy, even not with biologics, that they improved much or became quite clear, as you can see here, over a period of 4 months. Here, a patient with very severe psoriatic arthritis. She took every kind of biologic that is available, methotrexate, whatever. Nothing happened, but upon a gluten-free diet, the joints became completely free, and even the nails began to grow again. And another patient that could not be controlled by methotrexate and acitretin, but could not take another drug, also became clear. So the second part of the triggering mechanisms consists of environmental antigens that the body is being exposed to that may go into antigen processing, activate CD8 T cells, and then support the psoriatic autoimmune response that may be induced against B cells in the tonsils. And we know quite nicely from drugs that inhibit the emigration of T cells from secondary lymph nodes, like S1P1 receptor modulators, that these drugs are effective in psoriasis, like they are effective in multiple sclerosis, but they cannot be given because of severe adverse events. So what should we learn from this in terms of strategies? I think we know that tonsillectomy may improve psoriasis in recalcitrant cases, and my recommendations would be tonsillectomy may make sense in special cases. And there are certain conditions that need to come together. Psoriasis onset or relapses need to be seen in direct connection with streptococcal tonsillitis. The patients need to show, as you see here, enlarged chronically infected tonsils. We need to prove streptococci either by bacterial culture or by elevated antibody titers against streptolysin O or anti-DNase B, meaning streptococcal toxins. And the patients should have a positive family history for psoriasis, because this means that they have a high likelihood of being HLA-CO2 positive. Alternatively, we can use antibiotics to try to eradicate. However, you should always consider penicillin is not sufficient for this because it only works in the extracellular space. Streptococci, however, can integrate into cells where beta-lactam antibiotics don't work, so you have to take an antibiotic that has intracellular activity. Recommendations for patients in terms of exposure to wheat would be decide to avoid alimentation. Everything that is going along with wheat should be taken away, and then tested for 3 months, and once patients are satisfied, they should proceed with this kind of diet. So my last slide, avoiding exposure to certain environmental antigens may be a chance to improve psoriasis. That means streptococcal tonsillopharyngitis may be treated in certain conditions. Wheat, as the strongest trigger, should be eliminated from the diet at least for a certain period of time. But of course, having other antigenic triggers like alcohol or tobacco, this also should be included in such a strategy. It is usually the compliance of patients that makes this difficult, because just concentrating on something like wheat-free, gluten-free may not be possible for everybody. However, it is a chance, in particular, saving drugs, saving exposure to drugs and adverse events, and maybe improving overall the life conditions for psoriasis patients. Thank you very much for your attention.
Thank you so much, Jörg, for this outstanding presentation. It brings us indeed to triggering factors. It brings us to realize that it is not only asking for medications, focal infections, psychological stress, but that it's much broader and that it has an immune basis, what you tell us. Is it, when we look at the long-term course of psoriasis, we all know it's a chronic disease, but is it possible that maybe the immune status differs during life, and are there maybe promising biomarkers for the future to see whether the patient will be less responsive? In other words, is there also maybe in psoriasis the possibility of a cure?
Well, this is one of the most important issues, I think, that we consider how can we ameliorate the autoimmune response in a way that patients stop making immune activation. There are certain aspects that may play a role, and most of them are associated with a complex genetic predisposition related to psoriasis, which has many pro-inflammatory gene variants that somehow promote that an autoimmune response can be activated. This is the same for psoriatic arthritis, rheumatoid arthritis, for lupus. Once you have pro-inflammatory gene variants as a patient, then the HLA risk genes may become the relevant activating genetic element, and this we cannot change yet. Try to avoid inflammation, try to avoid environmental triggers, but for the moment I only see that inhibition or elimination of HLA-CO602 would be the actual
Yeah.
way.
And there we have a task as dermatologists to
Yeah.
contribute to this elimination.
Yeah.
Yes?
Thank you so much. Amazing presentation. I have, are you recommending tonsillectomy even in adults if I have proof? Because later on this afternoon I'm going to talk about children, and when they collected all the studies done, there was no concrete evidence that tonsillectomy was really beneficial.
Yeah.
Unless, like you said, I prove that there is a positive strep infection in the tonsils and repeatedly they're not treated properly with antibiotics. But what about adults? If, for example, some adults did not remove their tonsils, we have never thought about it. Do I ask about tonsils in older patients or certain forms of psoriasis, or it's just I look for it? Because I found this very interesting, and I think if we, even removing the tonsils is a simple operation, if I can do that, I might help the patient. So what do you think about that?
I have experience only with adult patients because every child will have a streptococcal infection once in their lifetime.
Yeah.
Children always have enlarged tonsils. That is just the lymphocytic state they go through. So the conditions I mentioned hold true, in my opinion, for adult patients. I would not tonsillectomize children, but I would still treat a streptococcal pharyngitis efficiently. And efficient treatment means that we should consider that streptococci have the ability for intracellular uptake. And this is the reason why they persist over months and years, and that always the same streptococcal strains are being isolated from the same patient over many periods of time. It's not a reinfection, it's a reactivation.
Yeah.
And the reason is actually intracellular persistence, in my opinion. And that means once we want to eradicate streptococcal pharyngitis, in particular in children, we need to use antibiotics that have activity within the cell. The issue is, unfortunately, that erythromycin is that many streptococci are, I think about 50% are resistant to erythromycin. So one would have to combine penicillin for the extracellular space with another antibiotic like rifampicin, or for me it is clindamycin.
Yeah.
And in this combination over 10, 14 days, it may be possible to really eliminate streptococci, but this is also medical experience. There are no studies following this. What we know from erysipelas is you can use prophylaxis in erysipelas to avoid relapses by depot penicillin or constant penicillin exposure.
Like long-acting penicillin once a month, like we used to prevent.
If you do it,
Yeah.
penicillin, you will have a relapse-free period unless you stop penicillin.
Yeah.
And then you have the same incidence of erysipelas as you have in patients who don't have prophylaxis. And it's the same with the tonsils. If you don't eradicate, in my opinion, in my experience, the streptococci will maintain and always reinduce bacterial infection by reactivation, not by reinfection.
Thank you so much.
Thank you so much. Really great. The next presentation will be given by Professor Hanan Nada from Cairo University, and it is on topical treatments.
Good morning. Thank you for inviting me to introduce a lecture here about topical preparation used for treatment of psoriasis. We all know that topical medication in psoriasis are the mainstay treatment, whatever the stage may be, mild, moderate, or severe. And the combination therapy usually bring a very favorite prognosis. As regards the topical therapies, approximately 70% of the patients are using this, and we are tailoring the medication to be used topically according to the case. First of all, I will speak shortly about the conventional topical therapies, which include topical corticosteroid. This is the mainstay, the cornerstone, by different strengths, mild, moderate, or potent steroid, according to the severity, according to the areas, and so on. Usually, we have a concern about the use of steroid in the face and the flexural areas because of the high risk of side effect. We all know that their mechanisms are anti-inflammatory and anti-proliferative in addition to immune modulatory mechanisms. The use of corticosteroid has a hazard of a topical as well as a systemic side effect, but the most important that we have to know that there is instance of relapse, rebound, and recurrence after stoppage of these corticosteroids, in addition to the possibility of the happening of the pastoral psoriasis with the use of steroid, especially high potent one. In order to reduce these side effects, it's better to use 50 grams per week, not more than this one. In addition, if there is a localized lesion, it's preferred to use it as in the form of intralesional steroid or topical under occlusion. The second is vitamin D analog, and we have different preparation, whether the old ones and the newly introduced one, whether in the form of ointment or in the form of gels that is easily to be used for the scalp. In spite of the fact that they are lower potent than steroid, but they have a more favorable adverse effect, more favorable in its long persistent action and prolonged remission of the case. And we have to know the addition of salicylic acid may impede or inactivate the use of a calcipotriol. In order to reduce the possibility of hypercalcemia, it's better not to use more than 100 grams per week for such patients. Sometimes we use it in the form of rotational, might be we use in combination in order to maximize the effect and reduce the side effect. Hypercalcemia is one of the concerns that we should take into consideration, but mild erythema and irritation can be encountered. The combination with topical corticosteroid with the use of topical calcium inhibitors is advocated, especially they will reduce too much the side effect of both. In addition, it will carry a high instance of efficacy of the case. The third is coal tar. 2,000 years ago, coal tar was one of the standards that we used because of the favorable effect on psoriasis that reduce inflammation and produce long-lasting remission. It was used in the form of shampoos, pastes, ointments in the form of 5 up to 20% concentration. But this one is not advocated now because of the staining, and the patients don't like it anymore. As regards tazarotene, which was one of the topical retinoids used in the treatment of some cases of psoriasis, it's also having a good prognosis, especially when it's used in the form of 0.05% up to 1% gels or cream. It may carry the irritation, but when we use it properly, no problem, especially if advise the patient to use sunscreen in the morning. The third is, after that, is topical calcium inhibitors. After a long steps inside the cell, it will inhibit the interleukin-2 cytokine, which is one of the pro-inflammatory cytokines advocated in the inflammatory process in psoriasis. They are used mainly in the face and the flexural area in order to reduce the instance of side effect of topical corticosteroid. After that, the emollients. Emollients should be used all over in all different types of psoriasis, mild, moderate, or severe, because they will help to hydrate the skin, to remove the scales. In addition, we know that the impermanence of the skin barrier in psoriasis now is it's considered and is consistent finding in cases of psoriasis, and when we repair this one, it will help too much. Keratolytics in the form of salicylic and urea. Diethranol also have been used before, but more or less not used anymore nowadays. The skin-directed light therapy in the form of directed ultraviolet B or excimer lasers, or even the pulsed dye lasers have been used also in some cases. As regards the novel treatment, the topical BDE4 inhibitors, the phosphodiesterase inhibitors, we know that it master the transformation from cyclic cyclic AMB into the cyclic into AMB, with transformation from the pro-inflammatory cytokine profile into the non-inflammatory, or the one that help to reduce the inflammatory process in psoriasis. Might be it take long time in order to introduce its effect, but it has a very good effect, especially when it's taken orally. Nowadays, there is topical preparation in the form of roflumilast, which have been approved in 2022 for the treatment of psoriasis in the form of creams and foam. It is indicated mainly in the face, in the scalp, intertriginous area, psoriasis, and also in pediatric. These are areas where we cannot advocate topical corticosteroid too much. For crisaborole, 2% concentration, it is approved for atopic dermatitis, but there are many case reports for the use of it in psoriasis, and now it is in some phases in order to get approval for its use in psoriasis. After that, the aryl hypochlorite receptor agonist. We know that after being steps inside the nucleus, it will master the many things that lead finally into decreased inflammatory cytokines, especially interleukin-17, increase the skin barrier proteins production, especially filaggrin and leucine, and increase the antioxidant response. All these ones will help to ameliorate the inflammatory process in psoriasis, and now tapinarof is one of the unique in this area, and it is now approved in May 2022 in the treatment of psoriasis and under trial for atopic dermatitis. The topical anti-JAK therapy for the treatment of psoriasis is also being studied in the form of ruxolitinib. There is a phase 2 trial for its use, but now in the pipe we have some new. The first is the nano-inhibitors targeting the c-JAK STING pathway. This pathway will master the process of anti-inflammatory effect inside the psoriasis, mastering the antioxidants steps inside the nucleus and inside the cytoplasm. And it will finally help to reduce the inflammation and decrease the cytokine inflammatory milieu in psoriasis. Also, there is the new techniques for the use of topical preparations to treat psoriasis and even systemic in the form of microneedling process with the solid, the coated, the dissolving ones, and so on, to improve the transepidermal delivery of the drugs, especially in resistant cases. And we can see here this one. Here we can see the microneedling. Here you can see the sheet applied on the skin. Then there is needles introduced inside where we can put the medication, and it has been tried for methotrexate. This will bring the effect of topical methotrexate on the plaques that is refractory or resistant to treatment, so that we can treat and we can get an efficacy and reduce the side effect. This is one of the recent advances, and here we can see also another. Here you see this is the sheet, and here the microneedles, and here this apply the methotrexate so that we can get the effect without side effect. Also, there is what is called curcumin-based ionic liquid hydrogels. The use of hydrogels also in the topical preparations used for the treatment of psoriasis, or even to use the systemic one to be delivered to the skin, is also have been introduced in the management of psoriasis recently, and which bring good efficacy and reduce the side effect. Finally, the emerging role of topical preparation or topical medication in psoriasis has now gained too much side by side with the biologic therapy. Finally, our aim to treat our patients whether by topical or systemic medication to get the highest efficacy and the lowest side effect. And thank you so much.
Thank you, Professor Hanan. Excellent presentation and concise and updated. Just wanted to ask you something. Peter likes it. Do you think there is a place in a country like ours to use tar? It's just a question. Do you think that in some areas we might, remember, Peter, you gave us an excellent presentation about tar. Yeah. Do you think you can use it, or it can be, of course, I'm not talking about the excellent updated creams that are out there, but for us, and you know, if we think about topical, what do you think about tar?
Yes, when we was a resident at Kasr Aini Hospital, we have the Jokerman
Yes.
technique, and we were using it. Excellent presentation, but the only anointment the patient is staining the offensive odor, and he knows it is a derivative from petroleum and so on. This is the one. But actually, we can use it. We can use it. Why?
Do you think can it be incorporated maybe in a nicer preparation?
Yeah.
Why not?
Why
Why
not?
should it be black and offensive and
Before, one of the big, without mentioning the Galderma, was making some
Yes.
preparation of tar
Yeah.
without the bad color, without the odor, and it was very efficient. The shampoo, I don't know why they stopped nowadays.
Yeah.
I think the new industrial techniques can improve the introduction of tar into a more acceptable preparation.
you think, Pete?
Yeah. Yeah, this is
especially that it's cheap?
the Jokerman technique was highly efficient.
Yeah, I think that is a very good thought. Of course, Tapinarov also actually hits a mechanism which is very important in tar treatment, aryl hydrocarbon receptor interference. But with the innovations that we have in the topical treatment of psoriasis, it is so expensive.
Yeah.
That is in many countries this will be a problem. It's a small tube of, not small tube, a tube of 60 or the 100 grams of Tapinarov that costs you between 1,000 and 1,500 euro. So you should be in the situation that you have Tapinarov and forget this tube when you are traveling in the train. That is terrible. You need nearly an insurance really to cover actually your topical medications. So that becomes impractical, but the reality is that in many of our patients, of course we start with topical treatment. We realize on the other hand also that psoriasis is a systemic disease, and there are also good arguments to be more upfront in the systemic treatment of psoriasis. But anyhow, when a psoriasis presents in its first manifestations, it's important to treat with a topical, but not to treat for many years and that the patient is not satisfied. Then you should earlier on try to switch to a systemic. For what is important is that we remain ambitious. But in special locations also, for example, psoriasis of the flexures, psoriasis of the face, for example, calcineurin inhibitors topically can be really very effective.
And genital also.
And we have to find the balance here of using topicals and at the same time not overusing them. And as dermatologists, we are inclined to take attention more about the topical approaches, but we should think also in terms of the psoriasis, systemic disease, and remain ambitious on those.
I think, thank you, Hanan, very much. Professor Prince, again, is going to talk to us about the conventional therapies.
Yeah, so number 2 of the talks. And I'm really grateful to Professor Nada, who really pointed out the issues. If we have an organ that is addressable, that can be targeted from outside, like the lung, mucosa, or the skin, of course it would be the primary idea to apply the particular drugs that should work in the lesions. And for me, just the needling, microneedling aspect shows what the major issue is. We don't get the drugs into the skin because the penetrance of large molecules is quite difficult. And I hope that in the future there will be some new approaches that will be able to somehow improve absorption or resorption in the skin. Okay, yes. And that leads us to conventional systemic therapies. Practical aspect. I'm not only doing research, I'm also a very enthusiastic clinician. And in my talk, I want to summarize a little bit the experience that I have to make conventional therapy safe. When we see psoriasis patients, we find a huge spectrum of severity and of clinical manifestations from localized plaques that may be accessible by topical therapy, but many patients like these that you see here require systemic therapy. The therapeutic options that we have by today are quite huge. We have topical therapy, as we just heard. Then we can expose patients to phototherapy. We have a group of conventional systemics, and there was really a revolution of psoriasis treatment over the past 20 years with several biologics, meaning antibodies that neutralize particular cytokines that are positioned in a bottleneck function in the psoriatic inflammatory cascade, and that can really, in my opinion, clear nearly every patient. And these drugs also show an increase in efficacy. Most of the patients respond to one of these biologics, while we still have a somewhat limited efficacy in numbers. The indication of these drugs, however, is depending on different aspects that are not only related to our medical assessment. It is psoriasis severity, but it's national regulations, it is efficacy, safety, it is guidelines. And with these aspects, we go through the treatment in order to finally potentially reach biologics which are the most efficacious drugs for controlling psoriasis. There's also a new group of drugs, in particular JAK-STAT inhibitors or the TYK2 inhibitors that both address the JAK-STAT pathway, but they have particular aspects that make them, for me, more or less a rescue therapy in patients. The increase in cost, which we already talked about in topical therapy, however, define that usually we have to start with the less expensive drugs if our health system should not be exhausted. And I want to share with you some of my personal experience with these conventional systemics. What can we achieve in efficacy? Acitretin, maybe 25–30% of patients will receive a physician's global assessment of 0 or 1. Methotrexate, close to half of the patient, and cyclosporin, more than 70% of patients can become clear or almost clear. Of course, we can read in textbook how to use them, and that would be information. But I like this phrase from Albert Einstein, who said, knowledge is experience. We need to know how to use the information in order to make it a safe treatment. For methotrexate, we should consider, and you may know this, of course, but I just want to repeat it once more, there are two major indications due to different modes of activation, mechanisms of action. On one hand, it is used in oncology. Here it is a cytostatic high-dose treatment which is antagonizing folic acid, competitively inhibits finally the synthesis of DNA, RNA, and proteins, which inhibits cell proliferation and therefore has a preferential effect on highly proliferating tissues. But there is a second mode of action, and that is the one that we employ when we use it as a disease-modifying anti-rheumatic drug. It acts by inhibiting an enzyme called ICAR transformase, which is relevant for the generation for the adenosine. Adenosine is an endogenous regulator of inflammation that mediates the transition from inflammation to healing through binding to various adenosine receptors. And any increase in the extracellular concentration of adenosine, which we can achieve by inhibiting the ICAR transformase, will then reduce production of inflammatory and increase production of anti-inflammatory cytokines, and also inhibit the proliferation of lymphocytes. So we have two mechanisms of action which are depending on the dose, high dose, oncology, low dose, DMARD. The indications for methotrexate in psoriasis are well known. There are two ways of application, either oral or parenteral. Oral would be 5 milligrams folic acid, in each case 5 milligrams of folic acid following afterwards. Oral application we still do according to the so-called Weinstein scheme. That means you apply the dose of 15 milligrams over 24 hours with an interval of each 12 hours in between. Alternatively, it can be applied intravenously, subcutaneously, or intramuscularly once a week, and I prefer to use it as a subcutaneous injection, and we can affect efficacy after 2 to 8 weeks. Like biologics, methotrexate has a strong added value because it really reduces mortality. It has cardioprotective effects. The total mortality over a period, in this case it was analyzed in rheumatoid arthritis, is really efficiently reduced, in particular also the cardiovascular mortality, and this is compared to the no methotrexate group. So we have two reasons to use methotrexate. On one hand, controlling disease activity, and on the other hand, improving life expectancy. Still, there are 3 hazards that we are, at least I was always afraid of. Alveolitis. We have to do a chest X-ray before we start methotrexate to have a reference in order to make an early diagnosis if patients start coughing. There's hepatotoxicity, which is either acute hepatotoxicity, which is idiosyncrasy, it just happens and we don't know why. But there's also liver fibrosis and cirrhosis with long-term therapy, in particular after a cumulative dose of 5 grams. We do fibroscans in order to find out if there's increased fibrosis in the liver, because it does not show in the increase in liver enzymes. The most scaring one, however, is myelosuppression. And in order to understand the mechanisms that are inducing myelosuppression, is essential to keep the drug safe. And this results from 2 different half-lives. On one, and this depending on the pharmacokinetics. Methotrexate is eliminated through the kidneys, and that makes a regular plasma half-life with normal kidney function of approximately half hours. While it is in the plasma, it is being taken up intracellularly, followed by polyglutamination. And polyglutamination makes methotrexate more effective, but gives it a negative charge, so it cannot leave the cell anymore. And that makes that it has an intracellular half-life of more than 12 days. Once it is taken up, it stays there. And the intracellular half-life determines the duration of the methotrexate efficacy, although we give it only once weekly. The major reason for methotrexate toxicity, and this is something that we can control as doctors, is the prolongation of half-life by impaired renal elimination. Wrong direction. So that is because the serum half-life determines the amount of intracellular methotrexate uptake. The longer we have a serum half-life, the greater is the intracellular methotrexate uptake. And that means that any decrease in renal elimination by whatever impairment of renal function increases methotrexate uptake and may lead to intracellular methotrexate accumulation. And that means if there's a prolonged period of delayed methotrexate elimination, we get an accumulation of methotrexate in the cell, and then suddenly a shift from the anti-inflammatory debut activity to anti-proliferative effects that primarily affect tissues with a high proliferation rate, granulopoiesis, megapoiesis, and are the main reasons for toxicity. What are the reasons for prolonged plasma half-life? It is impaired renal function, yes, and it is drugs that may interfere with renal elimination or plasma protein binding. And relevant drugs competing with renal elimination are non-steroidal anti-rheumatic drugs, which are over-the-counter drugs and patients can just buy and are not being controlled by you. But there are also other drugs that may be used concomitantly, like phenytoin or antibiotics or tranquilizers or phenylbutazone. So a major contraindication for methotrexate is impaired renal function. Once you see that creatinine is increased, once you see that you have some kind of other impairment in renal function, then this should be considered as a contraindication. And don't fuss around with the dose. I have seen patients with just a little increase of creatinine, but that still go in accumulation overdosage of methotrexate, even if we adapted the dose. And we also need to consider drugs which compete with methotrexate elimination. And I just want to give you an example of methotrexate induced myelosuppression. This is a case of a 60-year-old patient. We have taken care of him together with rheumatologists because he was suffering from psoriasis, quite extensive, and psoriatic arthritis already for over 40 years. And you can see here the X-ray from the feet, right more than left foot, and also the generalized psoriatic inflammation of the skin. And this patient had been treated with methotrexate 50 milligram already once weekly for over 4 years. And then he came, and he came not because of some complaints regarding the skin, because he had painful inflammation of the gingiva, which we call gum complaints, and he was quite fatigued. We saw that he's quite pale, and we also saw the erosive stomatitis that he developed. We did an emergency laboratory examination and could already see quite rapidly that the white blood cell counts had gone down. Thrombocytes were at the lower limit. Erythrocytes even had gone down as well, and he had a reduced hemoglobin. So we made the diagnosis of methotrexate-induced myelosuppression. But what were the reasons? Because of his joint pain, which was not completely controlled by methotrexate, he bought diclofenac, a self-administered over-the-counter drug, and took it 2-3 times a day. And this prolongs the plasma half-life and bioavailability of methotrexate because it impairs renal elimination. And that caused intracellular methotrexate accumulation and made bone marrow suppression. What are the clinical signs? You cannot take blood control every week over the 5 years in order to find out, but we have to inform the patients what are the clinical signs. They are necrotizing angina and gingivitis, and the necrotizing angina does not come from inhibition of proliferation, but it comes from the impairment of antibacterial defense against the oral microbiome because the granulocytes have gone. Then we find mucosal and skin hemorrhages, and we find sometimes monomorphic epidermal necrosis of all psoriatic plaques. And here you see some examples. Here is what you have seen before: gingivitis, erosive stomatitis, and angina. And this is a very typical sign. I don't know if you ever have seen it like this. All psoriatic plaques go into necrosis, and this is because methotrexate in these cases affects keratinocyte proliferation, and then you see erosions all over the place. This patient we could recover. This patient has died from the pancytopenia that she had developed. So these are the 3 things patients need to know about: throat pain, gum pain, erosive stomatitis, and necrosis of the psoriasis lesions. What do? Usually we check, of course, different values, hematology, kidney, and liver before starting. Then for the first 4 weeks, we do laboratory examination 2 to 3 days after starting methotrexate application. Then we do this every 2 weeks for the next 2 months, and then we do it every 3 months. And in case we still see methotrexate overdosing, we have leucovorin to rescue the patient. So the personal assessment would be, even in the age of biologics, methotrexate allows a safe long-term treatment of psoriasis and psoriatic arthritis if renal elimination, and it's again renal elimination, and renal elimination is the 3 major aspects we should consider, and drug-drug interactions to prevent myelosuppression. How about cyclosporin? It is indicated for severe patients with severe patients in whom conventional therapy is unsuitable or ineffective, in certain indications where we require a rapid disease improvement. This may be elective surgery. We had patients that want to marry, that want to wear a dress with free shoulders, and just ask for a rapid improvement of their disease. It is also used in pregnancy. However, it is only used for short-term treatment because it really has a toxic effect on the kidneys and increases blood pressure. I use cyclosporin at a dose between 2 to 5 to 4 milligram kilogram. The maximum dose would be 5 milligram. And there's one issue about dosing. it is dosed according to weight, but it is not dosed according to actual weight. So if you have an obese patient, you should never use the 120 kilograms to adapt the dose, but it is used according to the ideal body weight. So if there's a patient of 1 meter and 80 and he has an ideal body weight of 80 kilograms, then you should dose cyclosporine according to the ideal body weight. If you don't do it, if you use actual body weight, 150 kilograms, then the patient will experience severe kidney damage and blood pressure increase. So that is really the main aspect. The second main aspect is drug-drug interactions through CYP3A, which may be inhibited and therefore increases the exposure to other drugs. These are in particular the azoles, macrolide antibiotics, calcium antagonists, or oral contraceptives. However, most of these drugs are given only for a short time. The drug that is usually taken for a long time are statins. And statins are being increased in exposure by cyclosporine very much, and that causes rhabdomyolysis. So this is the main cause for drug interactions with cyclosporine. But patients never consider statins as a drug. They just say, this is to lower my blood lipids, and they may not tell you. And every patient that is being treated with cyclosporine by me is always asked, are you taking drugs to reduce your blood lipid levels? Once you have seen one rhabdomyolysis, you are very aware that this is an issue. So my personal assessment of cyclosporine is if drug-drug interactions, renal function, and arterial blood pressure are taken into account, cyclosporine allows safe remission of induction of psoriasis, but it's not suitable for long-term therapy. How about acitretin, the third conventional therapy? It is efficient in chronic plaque psoriasis, but not only up to 25% of patients will respond. It is particularly used for combination with phototherapy. One should start acitretin maybe 2 to 3 weeks before starting phototherapy, because then it is shows best efficacy. It is indispensable for generalized pustular psoriasis, acrodermatitis continuous suppurativa. You can control these diseases alone with acitretin. However, the patient may not tolerate the dose that is required, and it's also relevant psoriatic pustulosa palmoplantaris. I think acitretin is the only drug that can control psoriasis pustulosa palmoplantaris, and it may be used in psoriatic erythroderma. Once you have a patient on biologics, the patient doesn't respond sufficiently, you may add acitretin. What are the hazards? It's just written small hazards: women birth giving age. Retinoids are teratogenic because they impair the development of the brain in the growing fetus. It makes a derailment of blood sugar levels in patients with diabetes. It may increase or cause depression. It must not be combined with methotrexate. And it may induce inflammatory bowel disease that sometimes goes along with psoriasis. The potential drug reactions are low, increase in blood lipids, but this can be easily controlled. And this is the only thing I think is relevant. So acitretin is particularly suitable for combination with phototherapy, and it's the treatment of choice for me still in pustular forms of psoriasis. And the conclusions are, for me, conventional therapy, even in the age of biologics, still has a great justification and a good potential to control disease if we just consider these few aspects that are relevant to make them safe drugs. Thank you very much.
Thank you so much. Excellent presentation and very relevant to us, actually, saying how much conventional therapies are important. Does anybody have an urgent question for Professor Prince? Okay.
Over there.
Mahmoud. Yeah, go ahead.
Thank you very much. Excellent presentation. I'm just wondering about the efficacy of methotrexate, because what I have noticed in most of the published studies that measured the PASI 75 improvement, that they start low at 15 milligrams and then increase the dose if there is no response after a while. Well, I think, and this is just my impression or just my personal experience, that when we start high from the beginning at 25 and then go down in responders, we get a way better response than the protocol that has been used in most of the published studies.
Yeah.
I need to know your input about that.
No, I fully agree to your comment. What we see in studies is just the average of response to a certain dose. And then the issue is, do we start with a low dose in order to reduce the risk of toxicity, or do we start with a high dose like in cyclosporine or methotrexate to rapidly improve psoriasis? There was a very nice analysis maybe 15, 20 years ago about the efficacy of increasing methotrexate dose from 12.5 milligram or 50 milligram up to 22 milligrams, 22.5 milligrams. And this study found that if a patient does not respond to 15 milligrams, the patient has a very little likelihood that the patient will improve with increasing dose. However, on the other hand, that does not exclude that if we start with a high dose, we get a more rapid response than if we start with a lower dose. And therefore, I think it is up to our clinical assessment and clinical experience how we decide dosing for these drugs.
I think recently we published a Delphi consensus in the JAMA, and
Yeah.
I was part of it, and it was not recommended to escalate the dose of methotrexate. We start high and we don't do test dosing.
Yeah.
Because you know that a lot of people used to
Yeah.
do like this 7.5 milligram as a test dose, but this is not used anymore. Thank you so much. Thank you very much.
It's a pleasure now to announce the next speaker, and she will speak about phototherapy for psoriasis, very important area. Sahar Abdel Moers from Assoud University.
Assalamu alaikum. First, I would like to thank the organization committee for inviting me for this excellent conference. My talk is about simple subject, however, yet very important, because phototherapy is one of the cornerstones in treatment of psoriasis. I will go clinical, so we can get most of the benefit of this short talk. Phototherapy serves as a reasonable and effective treatment options for those patients who are not getting enough improvement using topical therapy, and yet they are not willing to go through systemic therapy. There are many types of phototherapy. The most common types are narrowband UVB, broadband UVB, targeted phototherapy as excimer laser and excimer light. Those two methods usually used in localized psoriasis where the body surface area not exceeding 10%. And of course, PUVA with its three common types. Several meta-analysis studies went through papers comparing narrowband UVB and other phototherapy methods. Although PUVA monotherapy have proved very effective and more even effective than narrowband UVB, as regard better response, shorter duration of response, lesser number of sessions. However, the short-term and long-term safety of narrowband and its lower cost and the simplicity and more convenience to the patient makes it superior choice or the first-line therapy as regard phototherapy and psoriasis. Narrowband UVB is also preferred over broadband UVB for the same reasons. So we'll talk about narrowband as an example of the phototherapy. It is recommended for adults with plaque psoriasis as monotherapy. It can get PASI 75 in more than 70% of the patient as monotherapy. It is recommended to give sessions twice or 3 times weekly. Of course, 3 times weekly give shorter response and shorter duration. However, the results are comparable. So if it's more convenient to the patient to start with 2 sessions per week, it's fine. To calculate the starting dose of narrowband UVB, there are 2 simple techniques. The first one, which is more simpler, is just depending on the skin type. So for skin type 1 and 2, we can start with 300 millijoule. 500 for skin types 3 and 4, and 800 millijoule for types 5 and 6. The more sophisticated, more accurate method is to determine the minimal erythema dose. It is determined using test areas, usually in the hip or buttock, as it's sun protected area. We draw tested area uniform in size, 2 by 2 centimeter, using this schedule where it shows the doses used for skin type 1 and 2 and skin types 3 and 4. Keep in mind, please, that for types 5 and 6, we do not determine minimal erythema dose testing. We just start with 800. The patient is asked to cover the area, continue cover for 24 hours, and then after 24 hours, we detect the least dose that cause minimal erythema as the minimal erythema dose, and we start with this dose as a beginning. For the subsequent visits, the response is usually assessed by the degree and duration of skin erythema, of course, and if there is any signs of burning. So if the minimal erythema lasts less than 24 hours, so that's ideal, and they will increase the dose by 20%. If the erythema persists for more than 24 hours, up to 48 hours, the dose should be held at previous level until erythema lasts less than 24 hours. And in cases where the erythema lasts for more than 48 hours, especially when it's combined with burning manifestations, no treatment should be given on that day, and return those to the last lower dose and did not cause persistent erythema. What if the patient missed a treatment? It depends on the days missed. So up to 1 week, we will hold the previous dose constant. 1 to 2 weeks, decrease the previous dose by 25%. 2 to 4 weeks, decrease the previous dose by 50%, and up more than 4 weeks, return to the starting dose. Some patients prefer to continue on phototherapy after clearance. In this case, we either taper the dose by giving the patient 2 sessions weekly for 1 month, and then 1 session weekly for another month, or we continue for prolonged maintenance by giving the patient a session every 1 or 2 weeks. Keep in mind that there is a maximum dose. It's calculated again according to the type of the skin. So it starts with 2,000 for types 1 and 2, up to 5,000 millijoule per square centimeter for types 5 and 6. But please note that the maximum dose for treatment for facial areas, whatever the skin type, is still 1 joule per square centimeter. Nowadays, there is more home devices for narrowband. The dermatologist impression is usually that these home devices will give poor response with much side effects, which is proven incorrect. They give comparable efficacy as regard the effect, side effect, and quality of life. The patients are usually even more happier taking the treatment at home. So, as regard combination therapy for narrowband, our aim with combination is to get better response with shorter duration, and of course, the more important is to get lesser side effect with both arms of the combination. Topical medications have been used in combination with narrowband for decades, especially corticosteroids, calcipotriol, tazarotene, and even coal tar. There is some conflicting results, few conflicting results regarding the improvement of calcipotriol, which is attributed to the degrading effect of ultraviolet rays on the vitamin D analog. However, the general confirmation is that they are all useful. Coal tar is very also effective in combination with narrowband, but please take care that it shouldn't be applied immediately after the narrowband. On the other hand, systemic therapies was also effective combined with narrowband UVB because of the major side effects that you usually see with these alternatives. Combining methotrexate and narrowband is well approved and well documented and give very good results as regard decreasing the side effects of both arms of combination. Oral retinoids being a non-immunosuppressive drug, relatively safe, it's very good to be combined with narrowband, especially in those who have higher risk of skin cancer. On the other hand, cyclosporin is contraindicated to be combined with narrowband UVB. We all know about the skin cancer risk that increase using cyclosporin. It is still not proven or theoretically to a great extent. However, it should be avoided. Some authors use cyclosporin sequentially with narrowband UVB, as they use small dose like 3 milligram per kilogram for short period like 4 weeks, and then taper the dose and then use narrowband UVB. This way it is more safe. Combining narrowband and ultraviolet A is not documented because the higher risk of ultraviolet exposure. In the era of biologics, adding biologics and narrowband UVB will of course add a lot of benefit to the effect of biologics. In general, combination therapy involving both items are very well tolerated. The most common side effect is erythema. Several studies went through etanercept, adalimumab, and ustekinumab regarding this combination, either giving them individually to different patients or by using a split body method. Half body shielded and half body exposed, and all researchers improved the efficacy of this combination, and especially when we face the secondary failure. Sometimes we face secondary failure using biologics, where the using of narrowband UVB comes very handy overcoming this obstacle. Ustekinumab and risankizumab is still very recent, no literature regarding their combination with narrowband. Of course, there are some concerns and contraindications should be kept in mind. There is risk of genital skin cancer and risk of ultraviolet-induced cataract. That's why we should shield the genitalia, and we should emphasize on using eye goggles to protect the eyes from any ocular toxicity. The photocarcinogenesis is, although the calculated risk of malignancy is still not that higher than the general population, still it's a theoretic risk, should be respected. Pregnancy, it's very safe to use narrowband UVB in pregnancy. However, using narrowband is reported to decrease cause folate deficiency very early during the first 4 weeks of pregnancy, even before that the woman knows that she is pregnant. So it is wise to start giving folic acid supplement in all women in the childbearing period using phototherapy to avoid the neural tube defect. This pathway for psoriasis is recommended by the American Academy of Dermatology. It's very helpful if you can go through it. There's no time for me to go through it, but it is very helpful if you can go through it. Thank you very much.
May I ask a question? You know, thank you very much for this talk that really reflects how to use phototherapy. And I'm very glad that you highlighted that the combination of phototherapy with cyclosporin is really contraindicated. We know this not least from transplantation patients that are under constant immunosuppression. And they are supposed to do really photoprotection, because about 20%, 25% of the casualties after kidney transplantation, for example, they don't come from kidney failure, but they come from skin carcinoma, which is being induced by UV exposure, natural UV exposure during immunosuppression. And I think the same holds true in a way for TNF antagonists. They show a higher incidence of actinic keratosis and skin carcinoma, and therefore we are also very careful in combining phototherapy with TNF antagonists, because skin carcinoma is a risk for TNF-alpha antagonists.
Yes, I totally agree with you. But may I ask you a question? Do you recommend using them sequentially, as some authors do, like using cyclosporin for a short period and then use UVB, or still the same concern about photocarcinogenicity?
I think due to the new drugs, we have changed the application of phototherapy. In principle, we use it in combination with systemic drugs. We start acitretin 2 to 3 weeks before, but we don't use immunosuppressive drugs when there's an indication for phototherapy. However, the main indication for phototherapy in my case is that either we have adverse events for systemic drugs or contraindications, or that the patients have gut-type psoriasis. The main indication for phototherapy now is gut-type psoriasis, which really nicely responds to it and which may induce a remission for half a year or year overall.
Okay, thank you very much.
Very good, thank you.
Okay. So it is my pleasure now to introduce Professor Peter van der Kerkhoff. He started his training in dermatology already in 1979, so you can see the extreme experience that he has. And this is not only for the early types of psoriasis treatment, he also participated in many clinical trials that are related to topical therapy, but also to the new biologic therapies. And so we couldn't have somebody better than Peter van der Kerkhoff to summarize the current use and experience with biologics. Thank you very much, Peter.
Thank you so much for invitation to this Congress. I really enjoy to be here. There are not so many congresses of dermatologists and rheumatologists, and it's a great idea really to have this, for I think that is important. Furthermore, I like very much to come to Cairo. I have been here a few times. It is impressive what's happening here. I have attended a few congresses, and I'm very impressed also by the enthusiasm, and especially around the enthusiasm related to psoriasis treatment. And with Professor Mahira, I am working in the International Psoriasis Council intensively together, and it always is a great pleasure to work with you, Mahira. Biologics in psoriasis. These are my conflict of interest. I'm working with many industries who are active in the field of producing new drugs in psoriasis. When we speak about biologics, what is the definition of a biologic? It is a substance that is made by a living organism or its products and is used in the prevention, diagnosis, or treatment of diseases. But it's produced by living organisms, and that means that these molecules usually are complex, are large, and in the production may vary from batch to batch. Biologics versus small molecules on this slide. Firstly, the chemical composition of a biologic is a protein, and for the future small molecules, which also are developed to target processes in the pathogenesis of psoriasis, these are small, these molecules. The administration of a big molecule is parenteral, and the administration of a small molecule is oral or topical. The molecular weight is much larger for a biologics, and the in vivo half-life is long in general. The target is the extracellular surface, whereas a smaller molecule interferes with the intracellular metabolism. The mechanism of action is usually blocking depletion, what the biologics do. A big molecule attacking another molecule in the body or a cell surface. And the small molecule acts more in enzyme inhibition. The specificity of a biologic is high, and therefore also as experimental dermatologists we like so much the results of the biologics these are very much targeted on aspects in the pathogenesis. And this gives also the clinician the opportunity to have a treatment with little collateral damage. It focuses, it attacks specifically a molecule, and it leaves the rest unattached. Generics are formed. After some time that the drug is in patent, a generic is formed. And for biologics, the biosimilars are produced. And biosimilars are not exactly the same. They are a little different in structure, but we should remind that also the individual batches of the originator biologics differ from batch to batch. A biosimilar is never the same again. As clinicians, we don't have any hinder of that, but it is in a certain range. But with the generics, indeed, it's identical. It's easy to make that molecule exactly the same as it is a small molecule. Let's have a look at the biologics. And this slide presents an overview, and I will approach it from a historical point of view. It's about 25 years ago that the first biologics came, and these were the anti-TNFs. There was etanercept, the fusion protein, a very nice biologic, but for the treatment of psoriasis, not so very effective. And then infliximab. Infliximab is a chimeric antibody, and this was an amazing result when you look after 10 weeks. But look, after a long time, and that's important, in the treatment of psoriasis, we are not for the quick fix, we want long-term efficacy. And there we see that there was loss of efficacy with infliximab in view of antibody formation. Furthermore, it's given as an infusion and not subcutaneous, so not so practical actually. So Enbrel and infliximab are a little bit, has a little bit disappeared for the treatment of psoriasis, especially psoriasis of the skin. In psoriatic arthritis, still it's used. Adalimumab. Adalimumab is a success story. Adalimumab is there, and now there are biosimilars for adalimumab, and they are available at a lower price. It's an antibody, and it has a very nice long-term efficacy. Golimumab, I even can pronounce it in the right way, golimumab is a drug which is not so popular, and the dermatologists, the rheumatologists know everything about it. And then there is certolizumab, which does not pass the plasma membrane, and therefore is very important in the treatment of women in childbearing ages. And then there was a revolution, the revolution of IL-12, IL-23, and that is the antibody, ustekinumab. I couldn't believe it when I heard that around 2005. A treatment which you only can give once every 12 weeks. That was a miracle for me, but it worked. And the efficacy is great. Also, the drug survival is great of this antibody. And ustekinumab, now the 1st of July, the patent has dropped, and also biosimilars will become available, and the price reduction will be there. So adalimumab and ustekinumab, great biologics which become available. And then the anti-IL-17s, secukinumab, brodalumab, ixekizumab. They have the same principle, more or less the same principle, and I give you later a little bit more in detail the differences, for they are all different. All, they have their own characteristics. And the same holds true for the anti-IL-23, so not the anti-IL-12-23, no, the anti-IL-23s. They all are different. I can be very short in the pathogenesis of psoriasis. I think what eloquently have been explained by Dr. Amer is the complexity of the pathogenesis of psoriasis. But to understand actually how biologics work, it's important to look to normal skin, normal looking skin. There can be as selective challenges of the skin, stimulating indeed the dendritic cells, and these dendritic cells then release IL-23 and stimulate the different classes of T cells to produce the anti-IL-17A and anti-IL-17F, which hit the epidermis, and the epidermis releases a host of molecules, immunocytes which come into the skin, and then the complexity of the psoriatic lesion is full-blown. And the other pathway, the autoantigens, where there's a stimulation CD8 cells, which also stimulate actually the release of IL-17, but in addition also IL-23. But now, from the treatment point of view, where do we find TNF-alpha? Nearly everywhere. TNF-alpha is very much distributed. It is a cytokine which is very important in many aspects. And that means also that it is more difficult to have a selective interference with psoriasis with less collateral damage. The IL-23 pathway is more specific, with the myeloid dendritic cells releasing this, but also with the resident memory T cells in the skin pertaining indeed memory. There is, but it is very much linked to the pathogens of psoriasis, and therefore the anti-IL-23 treatment provides a highly selective treatment, and sometimes it could be a little bit too selective for when we want also to have a good effect. For example, in psoriatic arthritis, it's sometimes better that we use an anti-IL-17. And there is IL-17 production, which is outside the control of IL-23, but at the expense of somewhat more side effects. Candidiasis we see more often with anti-IL-17 treatment and activation of Crohn's disease, which we don't see with anti-IL-23. So that's from the mode of action point of view. TNF-alpha, very broad spectrum. IL-23 may be more selective, and the anti-IL-17 a little bit in an in-between situation. When we look at the efficacy, these are data which are efficacy around 12 weeks, a very traditional slide. And the primary efficacy endpoint to look at, also in many meta-analysis, is the result after 12 weeks. In earlier days, we used the PASI 75 in the yellow columns, and in the other columns, you see the PASI 90. And we have actually, with more effective treatments, we are more looking to PASI 90. And what you see on this slide is indeed that etanercept has a somewhat low efficacy here. Infliximab has, after 10 weeks, a great efficacy. Adalimumab, ustekinumab have very acceptable efficacy. Okay, when we look to the IL-17 interference, it's important to realize that these molecules are different. There are other molecules like secukinumab and ixekizumab, which just hit IL-17A. Then we have bimekizumab, which interfere and block IL-17A and IL-17F. Then we have brodalumab, which interferes with the receptor and therefore blocks many different IL-17 molecules. And in that way, there is difference. There is some variation. When we look here at the efficacy, there are some comparative studies, for example, here for bimekizumab, showing the superiority above ustekinumab. And that's the, and also we see the superiority above adalimumab. And that is the first generation of biologics, the anti-TNFs and the ustekinumab have done great in psoriasis, but this is an extra step in efficacy, what anti-IL-17 and anti-IL-23 have realized. And here, for anti-IL-23, again here, primary efficacy endpoint after 12 weeks. And what we see here is the PASI 90, around 75%. You may say, hey, this is a little bit less than for the anti-IL-17s. Well, this little bit less is indeed, the fact is that anti-IL-17s in general act more fast. But when you look later, then this again comes together. What you see here, PASI 90, with the anti-IL-23s in the range of 80%. Network meta-analysis have been done. And the network meta-analysis after 12 weeks give an impression, and some authorities look very much at this efficacy endpoint, But what is more important is to look after more prolonged treatment. And this is a network meta-analysis after 44 to 60 weeks, which gives a general view. We see here on the left side the efficacy of methotrexate, apremilast, in terms of the PASI 75 response. We see etanercept, which is also in that range. We see that adalimumab and ustekinumab in the middle region really come to about between 60 and 70% of patients reaching the PASI 75. And then we move to the anti-IL-17s with secukinumab, having considerable efficacy between 70 and 80%. Brodalumab, ixekizumab, and bimekizumab tend to be somewhat more effective. Guselkumab and risankizumab are indeed very effective, and tildrakizumab is a little bit less effective. Is it important to compare and contrast the efficacy of all these drugs and then to say, and now we have the champion biologic and that is what we give to our patient? That would be poor medicine, for we need them all. That is, patients are highly different. Patients are highly different, and for often unknown reasons, some patients respond great also to drugs like methotrexate. Some patients respond great to adalimumab, and it is important in the voyage that we have with patients with psoriasis to discover what are the most important treatment options in a patient. And by experience, we can learn a lot. And experience is knowledge, what I understood here from you. Here on the left side, there's a knowledge here that is the cumulative drug survival of the classical systemics. And what we see, if we look in a negative way, we say, well, okay, after 1 year, 50% of the patients in general is off methotrexate or off fumarate or acitridine. But the good news is that 20% of the patients is, after 5 years, still on treatment. And that is important, that when you start with a classical systemic treatment, there is a population of patients who do very well. And these patients, of course, you can continue. On the right side, we see the drug survival for the biologics. And there we see that about 80% of the patients who are on guselkumab still are on treatment. And also that some 70% of the patients on ustekinumab still are on treatment. It seems that in the biologics, anti-IL-7 treatment is fast. And it seems that anti-IL-23 treatment needs a little bit more time, but is more sustainable and also after discontinuation of treatment. Personally, I don't like drug survival data so much as they are confused by all sorts of market developments. When new drugs are coming in, then suddenly from the others, the drug survival is short for a reason that the new drugs are available at some time. But absolute pass here in our patient registry. And what you see here beautifully is that indeed ixekizumab brought a very fast improvement. That's the lower line here. And that here, this line, guselkumab, needs a little bit more time, and then here they come about together. In real-world evidence studies, of course, a drug should be for some time on the market, and therefore you don't find here bimekizumab yet, these data. But real-world evidence studies are very important. Okay, nail psoriasis. I will keep it short. With topical treatment, with phototherapy, but also with the classical systemics, I'm so disappointed on the treatment and the management of nail psoriasis. Maybe you can inject with a dermojet corticosteroids in the nail, but biologics in general are very effective. And what we have seen, especially around ixekizumab, is a great efficacy. We have to reckon with the effect on comorbidities. The ACR50 response here, psoriatic arthritis, Still, rheumatologists tell us that anti-TNFs are great in the treatment of psoriatic arthritis, 45% reaching ACR 50 here, comparable with the treatment with bimekizumab. With respect to ustekinumab has a label in psoriatic arthritis, maybe not so effective in psoriatic arthritis, but there's good evidence that it inhibits the progression of rheumatoid arthritis. There is good evidence on surrogate markers that treatment with biologics actually reduce surrogate markers for cardiovascular disease, like here the change in non-calcified coronary plaque burden. Also, there are big data which have been analyzed on the effect of anti-TNFs related to cardiovascular disease, where there is a considerable reduction. However, when we look in the big patient registries, the evidence that the biologics inhibit and actually, or reduce, should I say, cardiovascular events is not yet available in a solid way. But there is ample evidence that cardiovascular risk is indeed improved by biologic treatment. I will be short for reason of time on the side effects, not that I want to give you a more positive appearance of these treatments where I have big belief in. Side effects of anti-TNFs in psoriatic patients, well known to you. You see them here listed. Ustekinumab. Also, what is important is virtually in all biologics, we have a somewhat increase in upper respiratory tract infections, but severe infections and malignancies, that is not what we see. And we see in the patient registries now ample evidence that actually this is not so much of a problem. Candidiasis and aggravation of IBD is an issue with anti-IL-17 treatments, and anti-IL-23 treatments have a very clean profile. Biosimilars. Natural variability is inherent to all biologics. Biosimilars are now available for adalimumab and are coming for ustekinumab. I would not have any reservation in switching from an originator product to a biosimilar which is officially registered. It is important. We have seen in our countries that a reduction by 90% of biologics is possible. And for adalimumab, that has been realized, and for ustekinumab, I expect that this will take place. Switching from originator to biosimilar had no significant impact on drug survival, and safety profiles were comparable. So, real-world evidence studies are done. So, in conclusion, biologics have revolutionized the perspective for patients with psoriasis. Long-term, effective, safe control of psoriasis is possible for the majority of patients. The treatment goal has to be ambitious. Arrest PASI less than 2, PASI 90%, high impact sites substantially improved, and comorbidities under control. Important to define the treatment goal together with your patient. We are not there, so when we are buying cars and look at the consumer guide and say, well, this car has the most crosses, we take this one. No, it's different. We are doctors. Psoriasis is a complex disease, and we make our decisions based on the different aspects. Adalimumab, ustekinumab should be available in all countries for patients who are not candidate anymore for classical systemics, and a personal treatment choice beyond a rigid stepwise approach that gives us the way to the right treatment. Thank you very much.
Thank you, Peter, for an amazing comprehensive review of biologics, and it's very interesting that the biosimilar of Stelara or ustekinumab is out, because this will make a lot of difference for a lot of the, because it's an excellent drug. I know Silvana here is sitting. She's the Janssen representative, so she's going to.
And less chance of activating tuberculosis. Huh?
Yes,
That is with
we're going to tell her, now you have to tell her that she has to bring the price down of the originator, and we will not use the biosimilar, so, right? Thank you, Peter, so much. Thank you, excellent. Last but not least, I would like to present my dear colleague, Professor Mahmoud Abdallah, who's going to give us the final part of this part of the symposium, which is the protocol that is used in the health insurance.
Thank you, Professor Mahira. Okay, so this protocol is the second edition, and that is applied in the HIO. The first edition, I prepared the first edition. No. A long time ago, and then Professor Mahira, my dear professor, and Professor Hanan, we made together the second edition. And what we do at the HIO, mild psoriasis is defined as patients with body surface area less than 3% or PASI score less than 5. Moderate psoriasis, 3 to 10, or PASI 5 to 10. Severe psoriasis, body surface area more than 10, or PASI more than 10. What are the treatment goals? The treatment goals is to achieve PASI 50 within 3 months, or body surface area reduction by 50%, or achieving body surface area of less than 3%. If we achieve any of these parameters, we consider this success of treatment, and to achieve PASI 75 within 6 months. While treatment failure is considered not achieving these parameters, and it is not allowed to shift from one treatment to the other, except if there is failure of the first one. For mild psoriasis, we use topical therapies, topical steroids mainly. For the face and intertriginous areas, we recommend TCIs. And if there is a good response, we recommend twice weekly application. And for patients with frequent relapses or inadequate response, we can add acitretin, methotrexate, or narrowband. For moderate psoriasis, the first line of therapy is narrowband. We can add topical, preferably crude coal tar, or PUVA. And the second line is methotrexate, followed by folic acid as a single dose. And for the third line is treated just as severe psoriasis. Severe psoriasis is treated by either PUVA or RePUVA as a first line. We did not include narrowband for severe psoriasis here. Second line, methotrexate. Third line, cyclosporin. And fourth line, biologics. Who is eligible for biologics at the HIO? Those who have failed at least 2 conventional therapies, provided they have a PASI more than 10, a body surface area more than 10, and or patients with severe palmoplantar psoriasis. And this is the only difficult to treat area that is included in the protocol. The protocol does not include treatment of nail psoriasis, scalp psoriasis, or genital psoriasis if the patient doesn't have severe psoriasis. So, if we fail 2 conventional, we give as a first line adalimumab, either Amgevita, Hyrimoz, Idacio, or Humira. No difference, whatever is available. If this fails, we shift to Stelara. If this fails, we shift to Cosentyx. If this fails, we can shift to Tremfya or Skyrizi. And if the patient, the doses are just the known doses for the drugs, including the loading dose, and if the patient uses adalimumab and wants to and stops it, he has to shift directly after a while to second line because of the possibility of developing antibodies. So I have to shift to Stelara directly. What about children? In children, the first line is Enbrel, 0.8 milligram per kg per week. The second line is Stelara, starting from the age of 6. And the third line is Humira. And the fourth line is Cosentyx. What about pregnancy? First line is Narrowband. Second line is cyclosporin. Third line is Cimzia. For erythrodermic psoriasis, first line is cyclosporin. Second line is Remicade. Third line is Cosentyx. And fourth line is Tremfya. For pustular psoriasis, the first line is acitretin. Second line is cyclosporin. Third line is methotrexate. And fourth line is Cosentyx. For guttate psoriasis, the first line is Narrowband, and the second line is methotrexate, and to be combined with antibiotics if antistreptolizant O titr is elevated. For patients with mainly psoriatic arthritis, we have to follow the protocol that is prepared by our rheumatology colleagues, which includes adalimumab as a first line, Cosentyx as a second line, and Tremfya as a third line. Patients who are coming to the HIO already on a drug are not allowed to receive the same drug. They have to follow the protocol from the beginning. And this is because at the beginning we were allowing patients, for example, on Tremfya, to just come and receive the Tremfya at the HIO. And then the self-paid patients were paying for the first dose and then come to us and say, we already have one dose, so please give us Tremfya. So we prohibited this altogether. They have to follow the protocol from the beginning, even if they come to us, if the patient is self-paid and got the first dose out of pocket. Thank you very much.
Thank you, Mahmoud, for presenting the protocol. They just told me that we are out of time, so I think this concludes our session because there is another session.